Welcome, everyone. We'll allow a few minutes for people to continue to join. It's so exciting. I'm seeing the attendee count just climb higher and higher. For those of you who just joined, welcome. We're allowing a few minutes as people trickle in. When I see that attendee count stop climbing, I will go ahead and start the webinar. Give a little bit more time. Okay, we'll go ahead and get started. That attendee number has stopped climbing. Well, I'm so thrilled to see how many of you have joined us because this is such an important topic. This webinar focused on expanding school-based services through Medicaid. As we all know, in the COVID-19 pandemic, schools have closed, families are facing economic hardship on a massive scale, and access to healthcare has never been more important. So I'm thrilled for today's webinar. I want to mention it as a collaboration between Child Trends, the School Superintendents Association, and the Healthy Schools campaign. So here are a few logistic tips as folks are joining. You can use computer audio or phone audio during the webinar. All attendees are muted. You do not have to worry about that. During the Q&A portion, which we will hold to the end, please use the question box to type in your questions and a member of our team will read them off. And if you experience technical difficulties, please put that in the question box, or you can send an email directly to our team member, Emily, and her email address is there. I thought it would be helpful to start this webinar grounding us in why this matters. Studies show us that 1 in 3 school-age children rely on Medicaid to meet their basic health needs. And there's disparities in who's getting their health needs met. Nearly 1 in 5 Hispanic children have not had a well child visit in the past year. This is a greater gap for Hispanic children compared to children of all other racial and ethnic identities. Children from low-income families are 6 times more likely to have no usual source of health care. And school nurses are least common rather than most common in schools serving low-income children. So school-based health services have the potential to improve health equity among children and ultimately also educational outcomes, as we know healthy children are better able to learn. It's my pleasure to introduce our wonderful speakers today. First, you'll hear from Sasha Pudelski, the Advocacy Director for the School Superintendents Association. And she will cover a primer on Medicaid in schools. Next, you'll hear from Alex Mays, the Senior National Program Director of the Healthy Schools campaign. We'll talk about the free care rule change and its implications. And finally, you'll hear from me, Dr. Andrew Wilkinson. I'm a research scientist at Child Trends, and I will be covering the results of a study we did of the free care rule change. And boy, did we learn a lot. I'm glad you all are here because we learned a lot of lessons learned from the states who are the first to implement changes to take advantage of the free care rule change. So with that, I will turn it to my co-presenter, Sasha.
Great, thank you, Andra, and thank you everyone for joining us. I'm so glad to be here to talk about such an important funding stream, even when there's no pandemic happening, that allows school leaders to hire healthcare workers and school personnel that can meet unmet health needs of low-income students. Medicaid is actually the 3rd largest funding stream, right behind Title I and IDEA for districts, and yet it's a drop in the bucket in terms of Medicaid expenditures. Less than 1% of all Medicaid funding goes to schools. So it's really important to us, but not so important a program to the administrators over at HHS. And there are several different ways that schools are entitled to reimbursement from Medicaid. They can provide, of course, direct medical health related services to kids who are eligible for Medicaid. They can perform administrative activities in support of the state Medicaid plans, such as actually enrolling kids in Medicaid or doing care coordination or transporting them to providers or to and from school. Or they can do both of these things. Next slide, please. And Medicaid has been a source of funding for districts since 1988, when the Social Security Act was amended to allow districts to bill for students who need certain medically necessary services and also qualify for IDEA. IDEA stands for the Individuals with Disabilities Education Act and is the federal statute that governs how districts educate kids with disabilities. The crux of IDEA is the development of what's called an IEP, or an individualized education program, which dictates the services a child may need to receive what's called a free or appropriate public education in the least restrictive environment. And those services can include things like audiology, nursing, speech language pathology, occupational therapy, physical therapy, personal care, and mental health services. Next slide, please. But just because a kid has an IEP and needs these services doesn't mean that a district can get Medicaid reimbursement. There are multiple conditions that have to be met for districts to receive Medicaid reimbursement. First, and importantly, the state's Medicaid plan must actually cover the services. Second, the student must be eligible for Medicaid. Third, the services have to be provided by a qualified Medicaid professional within the scope of their practice. And finally, the services must be medically necessary. So if these conditions are met and the parent consents to having Medicaid reimbursed, having the school district reimbursed rather, and something also called third-party liability is met, public schools can then be eligible for reimbursement. Next slide, please. But I'm going to talk about one of these pieces in particular, the parental consent piece, because it's one of the thorniest Medicaid reimbursement issues for districts, and frankly, it just doesn't have to be this way. When IDEA was last reauthorized in 2004, a regulation was issued by the U.S. Department of Education that required districts to obtain parental consent in order to bill Medicaid. Now, if a Medicaid eligible child is seen by their pediatrician, Medicaid is automatically billed and that provider is reimbursed. But for whatever reason, the department decided that they would have to actually the district would have to obtain consent to bill Medicaid for the exact same service that they're delivering to a child in a school setting. So they make parents actually sign a consent form saying, yep, I agree that the district can bill Medicaid for, say, speech therapy that my kid's getting. But this consent form often confuses parents and actually discourages them from granting permission to bill Medicaid. And as a result, it's a really major hiccup in districts getting reimbursement that they are entitled to. Next slide. Other major challenges for receiving Medicaid reimbursement for districts relate to some specific rules that the Centers for Medicaid and Medicare created back in 2003 in their school-based claiming guides that set out a series of pretty complex processes for receiving Medicaid reimbursement for districts. So in addition to having an IEP that describes the services that are required to meet a student's needs and the parental consent form I just mentioned, districts also need to document the medical conditions for which Medicaid services are delivered. They have to have a referral form frequently for billed services from a physician outlining the medical necessity of the service. They need to document the services that are being delivered, including confirming that the person who's delivering those services is a qualified Medicaid professional. And then they have to have a narrative after each session with the child that documents the service or progress notes about the session and how it went. So it's a lot of paperwork is the bottom line. Next slide, please. So let's talk about how that reimbursement then is calculated. Certainly it's not a dollar for dollar reimbursement. It's not like, oh, districts spend $1 on a healthcare service and the federal government reimburse them right back for that dollar. It's definitely a very small amount, but it's meaningful. And there are two primary options. There's fee-for-service and cost-based reimbursement. So fee-for-service is what it sounds like. The state decides that for, say, again, occupational therapy, for example, for an hour of that by a Medicaid qualified provider, the district will get back $45. So the district then calculates how many kids got an hour of OT, and then they can kind of guess what the cost is going to be for those services and what the reimbursement will be. Now, cost-based reimbursement is a little bit different. Schools receive periodic interim payments during the year from the state Medicaid agency, and these are based on the cost the school district estimates they are going to incur to deliver Medicaid eligible services. Now, at the end of the school year, the district calculates what they actually spent, and then they compare that amount and decide whether or not they owe money or they're getting more money back from the state, but they have to kind of close that out. And then two other ways that they can get reimbursement is, again, through the administrative claiming piece. So if they do those services like Medicaid outreach and enrollment activities, they can get reimbursement. And they can also perform something called EPSDT, services that are in Medicaid. That stands for Early Periodic Screening, Diagnosis and Treatment Program. And those benefits that a child is entitled to include things like vision and health screenings, diabetes and asthma diagnosis and management. And those are services that the school nurse or some other person can provide that can also be reimbursable. Next slide. So given that the Medicaid reimbursement process can be quite difficult for districts, why do we do it? The basic answer is that sick kids can't learn, and kids with unmet health needs can't learn. And the unfortunate reality is that even pre-pandemic, we had more kids coming to school with health needs that prevented them from learning than ever before. So yes, schools are not hospitals. We aren't doctors' offices, although many of us have health centers connected to us. Our primary job is actually educating kids, but we can't do our primary job if a student can't see the whiteboard or hear the teacher or is struggling to breathe or speak or move or communicate. So that's why Medicaid is so important. And when we already are not investing enough at the state and local and federal level in education through our traditional education funding streams, Medicaid provides critical supplemental funding, particularly when it comes to special education budgets. That ensure the districts can be compliant with IDEA and also just employ the school personnel we need to ensure that kids can actually learn. Next slide. Now, we at AASA wanted to better understand just how burdensome the Medicaid paperwork issue was for districts. So we conducted a survey in December of 2018 of schools in 41 states to ask them, what has stopped you from participating in the Medicaid program? And the answer, as you might have guessed, was paperwork. The administrative requirements can be really intimidating. Again, we are not healthcare centers primarily. We are education centers. And so we frequently don't have the personnel who can take on this kind of paperwork. And some of us can't afford to outsource it. Another challenge is actually finding providers that will work in school settings. The paperwork demands are much higher often in schools than in clinical settings, and licensure is also challenging. So that's another difficulty. And then the cost of doing the paperwork can outweigh the reimbursement that districts receive. Next slide, please. And this is particularly true when we look at rural districts. In our report, we found that 25% of the rural districts we surveyed said they stopped participating in the Medicaid program because they lost money due to the cost of complying with paperwork. And even districts that are high poverty sometimes just can't do this. They just don't have the capacity, the in-house capacity to do this paperwork. And so next slide, please. You'll see that, you know, our conclusion is that there's a really significant portion, particularly of small and rural high poverty districts, that do not seek Medicaid reimbursement despite having a high proportion of students who qualify for Medicaid reimbursable services, as well as an urgent need to have Medicaid providers deliver healthcare services to kids in schools. So what can be done about this? We need to make this program more equitable. While there's a number of things we can do to improve the program itself and enhance its integrity, while at the same time making the paperwork burden less so that all districts have the ability to pull down funding for these healthcare services they're providing. But I'm actually going to turn things over to my friend Alex, who's going to give you a great example of the kind of administrative actions that can be taken to expand access to the Medicaid program for kids in schools.
Great. Thank you so much, Sasha, for kicking things off. I love following Sasha and co-presenting with her because she does such a fantastic job of just providing that overview and teeing things up. So thank you so much, Andra and the Child 10 team for having me. My name is Alex Mays. I'm the Senior National Program Director with Healthy Schools Campaign. We are a national nonprofit, and all of our work really sits at this intersection of health and education. And really, for the last decade, core to her work has been this issue of supporting states in implementing strong school Medicaid programs. Since, as Sasha shared, it is a critical funding stream for schools, and we believe is a really important strategy to addressing the healthcare needs that students come to school with. Healthy Schools Campaign for the last 4.5 years has run a national learning collaborative called the Healthy Students Promising Futures Learning Collaborative that has 15 state teams in it, and they are all coming together to work around supporting expansion of their school Medicaid programs. So a lot of the information that I'm going to share today comes from lessons learned from that group. And so really what I want to do today, next slide please, is build on the information that Sasha shared and set the foundation for a key opportunity that states have right now to expand their school Medicaid programs. And this was really the core issue that Child Trends looked at. So we wanted to level set with everybody so that you all have an understanding of this key opportunity. So as Sasha shared, kind of historically, Medicaid has really only reimbursed school districts for health services that are included in students' individualized education programs, or IFSPs as well, for those students that are enrolled in Medicaid. And this has led to robust school Medicaid programs across the country. 49 out of the 50 states have school Medicaid programs in place. But only 14% of students have individualized education programs. So this school Medicaid programs across the country have really been built on only being able to seek reimbursement for services included in those individualized education programs and delivered to a smaller percentage of students. And that was specifically because of language that was included in some guidance that came out from Centers for Medicare and Medicaid Services to states and school districts around school-based claiming that included that restriction that only services included in students' IEPs or IFSSPs could be billed. And so advocates across the country really, for a number of years, worked to engage with Centers for Medicare and Medicaid Services to have that policy change, because we felt that, schools are providing critical services, and we knew that schools are providing many more services than those that are just included in students' individualized education programs. And so we wanted to see schools really recognized as a site of service for healthcare services and ensure that they could be receiving Medicaid reimbursement for that full scope of services that they're providing. And so in 2014, Centers for Medicare and Medicaid Services issued a state Medicaid director's letter that clarified that states could allow school districts to seek Medicaid reimbursement for any Medicaid eligible service delivered to a Medicaid enrolled student. And this has come to be known as the free care policy reversal, and really is what we're going to spend the rest of the presentation really digging into and talking about what that kind of rollout and impact has been of this policy change. Next slide, please. So just to really summarize what this Medicaid free care policy reversal means is that Medicaid reimbursement is no longer restricted to those services that are included in students' individualized education programs. And Medicaid will reimburse for services delivered to all Medicaid enrolled students. So this really means that school districts can, now have the opportunity to seek reimbursement for that full scope of EPSDT services that Sasha mentioned. And we, really see it particularly as a tremendous opportunity for seeking reimbursement from mental health services. I do want to note that while this policy change happened and the state Medicaid director's letter was released, it is by no means a mandate, and states have to make the choice to expand their school Medicaid programs. In the time that the restriction was in place, saying that states could only allow school districts to seek reimbursement for those services included in students' IEPs, many states formalized this free care policy within their state Medicaid plans. So there's often language in state Medicaid plans that specifically says that school districts can only seek reimbursement for those services included in students' IEPs or IFSPs. And so what needs to happen in the majority of states is that states need to submit state plan amendments to change their state Medicaid plan to remove any restrictive language. State Medicaid plans are meant to be living documents. They're updated regularly. By no means is this an insurmountable barrier. It's just an extra step. And I really want to underscore that even though this change has happened, it may not be an opportunity yet in your state. I'll speak a little bit more in a moment about the states that have expanded this. But the opportunity is there for states to take advantage of. Next slide. And so what this really means, building on Andra's opening remarks and what Sasha shared is, this is a chance to increase funding for school-based health services. And ultimately, our hope is that increased funding can be leveraged to deliver more services in schools and really expand the healthcare workforce that is available to students within schools. preliminary data that we've seen really promising increases from some states that have expanded their programs. North Carolina is a state that expanded a couple years ago. They have seen a 35% increase in federal Medicaid revenue as a result of their expanded program. We've kind of seen similar projections from some of the other states that have expanded. And so we really are, talking about potentially millions more dollars coming into schools to support the delivery of school health services. And I think really at the end of the day, this is about recognizing schools as another site of service for healthcare services, which is a tremendous opportunity. And I think has also really encouraged some new and innovative thinking around how schools and healthcare can really work together to meet the needs of students and support health and academic outcomes in schools. Next slide. So again, just to emphasize that states, need to choose to expand their school Medicaid programs to cover all Medicaid enrolled students. I think another key point to underscore is that a trend we've seen is that as states have been looking to expand their school Medicaid programs, they've also really been very thoughtful about looking at the providers that are in schools delivering these services, looking at the services that are being delivered to students, and thinking about what additional providers and services they want to add within their school Medicaid program. So we've seen a lot of states that have moved to take advantage of this opportunity, add different providers such as school psychologists or behavioral health analysts to their programs, or do things like add vision services or dietary services. So it's really a chance for states to kind of do an assessment of their program and think about how they might build on what they have and really make sure that the folks that are in schools delivering services and that the services that are being delivered are Medicaid eligible. Next slide. So just to, kind of share where we are now, many states are considering taking advantage of this opportunity. To date, 13 states have expanded their school Medicaid program. I, shared that it's actually almost exactly 6 years ago to the day that this policy change happened. And initially, I think uptake was a little slow, but I think that was primarily, as Sasha shared, school Medicaid programs are less than 1% of overall state Medicaid budgets. They're a drop in the bucket. I think, these are programs that often aren't on the radar as much of state Medicaid leadership, and rightfully so. There were a lot of competing priorities initially when this change happened. And so I think a big part of kind of the uptake, the time it's taken to take up this opportunity has been just it being elevated, up to the attention of key decision makers. And I think also there was some hesitancy among states to really understand what this meant and make sure that it truly was an opportunity to expand programs. And so once we saw the first couple states, shout out to anybody from Louisiana or Massachusetts that are on the phone. They were the first two states to move out with this change. Once we really saw those changes come through, I think states felt a lot more comfortable moving forward and were able to pull language, as far as what was in their state plan amendments. And then states very quickly followed. So it's really been in the last year and a half or so that we've seen a significant increase in states really seizing this opportunity. Next slide, please. And then this is just a map of kind of where things are as far as expansion. The dark green states are states that have expanded their school-based Medicaid programs through that submission of a state plan amendment and received approval for that. There are a number of states that do not need to submit a state plan amendment. And I know as a part of child trends analysis, they look very closely at kind of what action was required state by state to move forward with this opportunity. So I encourage you to check that out to see where your state kind of falls on that spectrum. But South Carolina, Missouri, and New Hampshire have moved forward with expanding their programs without state plan amendments. And then we have Georgia and Oregon have submitted state plan amendments and are awaiting approval. Next slide. And so just to really, I think, kind of just spotlight one example of what this could look like. One of our favorite examples is Michigan. They had their state plan amendment approved in the summer of 2019. I think they were very thoughtful in terms of thinking of the infrastructure that would be needed to implement an expanded program, and they actually passed legislation the year prior to their state plan amendment approval that allocated a significant amount of funding to really increase their provider workforce within schools. They did that. They allocated $31 million to do that, but really with the recognition that then submitting and getting the state plan amendment approved would be a sustainable way to continue funding those healthcare workers. So they felt like that initial upfront investment was well worth it, and that they would get that money back and more by successfully expanding their program. And their projections for implementation do certainly seem to indicate that they will do that, recover that amount and then some. They added a significant number of providers. This is the list. And just so again, a really nice opportunity to look at providers that are working within schools and think about additional Medicaid eligible providers that you want to see. A big emphasis we've seen has been on mental health providers, which is fantastic given, certainly the student needs around mental health and wellness. They added school psychologists as a part of this expansion, and just from billing for services that school psychologists are delivering within schools, they estimate that $14 million in new federal funding will come just from billing from school psychology services alone. So we're excited to kind of see what the full impact of that expansion will be once they're up and running. Next slide. So just to kind of wrap things up, I think there is significant momentum building around school Medicaid programs. We have seen a lot of that really driven by concerns around mental health and school safety. And certainly we recognize that now more so than ever, supporting health of students is going to be of critical importance as schools reopen. And so we see this as a really important strategy for states to pursue to bring in additional resources to do that and really ensure students have access to the healthcare providers that they need. Next slide is just my contact information. Please don't hesitate to reach out to me with any questions. And then there's a link here to a brief that we maintain that has more specifics about every state that has pursued this policy change. So I will now hand it back to Andra. Thank you so much.
Thank you, Alex and Sasha. You guys gave me quite the act to follow. That was wonderful. I learned a lot from the presentation. So I will be presenting a study that we did. It was a partnership between Child Trends and the National Health Law Program on how state free care policy influenced state Medicaid expenditures in public schools and lessons learned from those early implementers. And I want to acknowledge our partnership on this with the National Health Law Program, or NHELP, and this project was supported by a grant from the Robert Wood Johnson Foundation. I also want to acknowledge the team that made this work possible. The lead on this team was Kristen Harper. The co-lead was Dr. Brandon Stratford. Our lead partner at NHELP was Sarah Summers, and I was the project director of this project. We'd also like to acknowledge Judy Wallace, a consultant with Fairbanks LLC, who helped us on this project as well as a consultant. So this project had three arms. The first arm was a policy analysis. Our partners at NHELP read state Medicaid plans, managed care contracts, and managed care contract RFPs when they couldn't get the contract, as well as state plan amendments. Collected that data and searched it for language like health services can only be reimbursed if they're part of an IEP, the exact language that Sasha and Alex referenced that can prevent a state from taking advantage of the free care policy reversal. So we did a policy analysis. We also did a finance analysis looking at state Medicaid expenditures for school-based health services, seeing if they are different from states that have kind of policy level barriers and states that don't. And we also did a qualitative analysis, interviewing state and district leaders who are early implementers to expand health services through Medicaid to get their lessons learned. And due to time crunch, I will not be going in detail on the policy analysis. You can see the results in the finance analysis, but our full report of this will come out on Monday of next week, in which there are tables and tables of information you can dig into with specific language. We included the specific language that we found in a state Medicaid plan that could present a barrier. We hope that resource is helpful. So jumping into the finance analysis. Our research question was to understand, did states without policy barriers to take advantage of the free care rule change have different expenditures for school-based health services following the 2014 change compared to states that do have barriers? We used 3 different data sources: annual enrollment reports from Medicaid from 2010 to 2018, the Medicaid financial management reports over the same time span, and then the NHELP's policy scan. And we used these data to come up with a measure of state expenditures on school-based administration and services per enrolled child. And we did this so we could have an apples-to-apples comparison between states. As we know, states have very different sizes of their Medicaid enrolled population. This calculation is a common calculation that's done even by CMS as a way to look at per capita expenditures and compare states. And this is what those data looked like in 2010. So the size of the bubble for a state is the size of their per enrolled child expenditures on school-based services and administration in 2010. The states that are orange are states that we flagged could have barriers for taking advantage of the free care rule change. The states in blue are states that do not seem to have barriers to take advantage of the free care rule change. And at this, we went back to 2010 because we thought it'd be helpful to see how the trend shifts over time, and it allows us to see changes that happened before 2014 and then changes that happened since. And first thing we see at this baseline is that the national average is about $100 per child, 97. But we also notice variation. There are states that are spending twice, 3 times, 4 times, and 5 times as much as this on their school-based services and administration. This is what those data look like in 2014. So this is the year CMS shifted the interpretation of the free care guidance. And we see the national average has gone up. It went from $97 to $142. We see more state variation. A lot of the bubbles got bigger. A lot of states went from 0 in 2010 to a dollar amount. We still see significant variation. The variation has actually increased. And then the next slide, we're going to jump to 2018. So you'll see a new shape on the map. Square-shaped states are the states that you saw on Alex's map. These are states that are the early implementers and starting to expand services. So we're watching them closely, as they might be the first to have kind of an increase in expenditures. That's what we are looking for. Another thing to note here is 9 years later, in 2018, the average state expenditure on school-based services and administration per child have gone up $75, $76 to $173. So we've seen growth over time. And if we take these data and plot the averages in the states that don't have barriers, the blue line, and the states that may have potential barriers, the orange dotted line, we see 2 things. Expenditures are going up over time, but there's no statistically significant difference between those 2 groups. Looking at this graph, we were looking to see if there was a big tick upwards in the blue line in 2015, 2016, 2017, or 2018, and we didn't see that. And there's a couple of reasons why, one of which Alex mentioned, that states didn't race to implement this change, so it was likely optimistic that we would see a change just 1 year later in 2015. We also know from talking to states that there was a delay in implementation between, it takes time to develop and create your state plan amendment, submit it, wait for approval, train your staff, fully implement and scale the change. That takes time. We also know that states are at very different points along that spectrum. The data also were quite volatile, so there's large year-to-year changes in expenditures, which we're still trying to understand why. One big contributor we learned is that CMS introduced the line item in expenditures for school-based services and administration during our study period. So between 2010 and 2018, there was a new line item and states were reporting these expenditures. So when we're looking over time and we see a state, we saw so many states go from 0 to a number, that could be because they expanded services, or it could be because they already had those services, but they were charging them under a different line item. So we keep those things in mind as we're looking at these data. I do want to mention those pretty maps I just saw in our final report that's going live on Monday of next week. That data visualization is fully interactive. So you can click around, click on your state, click years, play it forward. So we hope that that is a helpful resource for everyone. Moving to the qualitative analysis. So we had 3 goals here. One, to understand the school Medicaid policy shift and what that looked like across levels of state and district administrations, both on the health and the education side. We also wanted to understand the perceived effect of the school Medicaid policy shift on health disparities and health equity. And we also wanted to understand successes and challenges in implementation. And one learning we had pretty early on was that states were using the language, and you heard Alex say this, of expansion. They were not using language of free care. And when we were talking to people, they often referred to it as expansion because it expands reimbursement from IEP services to all Medicaid eligible students in a school. So we did talk to 6 different states, and then we did 11 interviews in districts in 3 of those states. Our team is proud that we talked to states in different regions of the country, red and blue states, small, medium, and large states, states with varying degrees of racial and ethnic diversity, and states who were early, mid, and late implementers of expansion. At the district level, we also made sure to speak to rural, suburban, and urban districts, districts with varying levels of racial and ethnic diversity, and small, medium, and large districts in terms of student population size. So we really feel like we got a fairly good representation. And there's a lot of great tips and lessons learned on the next few slides. I'm only going to enumerate a few of them. So I encourage you to see all of them in the full report. And I'm just going to say what the finding was, and then it's mostly quotes because I think it's important to lift up the voices doing this work, because you can see what they said rather than hearing what we think they said. So move to that next. So the first finding was a lot of states and districts, and I should say we only present something here if more than one state or district mentioned it. We know state Medicaid plans can really vary state by state. So we only pulled up things that seem to be a commonality. Several groups were mentioning them. So one big one we heard a lot was the value of engaging leaders from state health and education leaders early in the process. This quote highlights we would, starting with a collaborative approach at the front end often saves you grief on the back end. So reading a little bit from it, we would rather get that stakeholder input and that collaborative approach from the beginning than try to play catch up on the backside. This is from a state leader from the State Department of Education. The next finding was the value of building relationships with community and advocacy organizations. So in this example, the respondent from a State Department of Health and Human Services talked about the value of building these connections and using data to build those connections. So they use data from the Youth Risk Behavior Surveillance System, or the YRBS, to highlight in particular mental health needs, as Alex mentioned. So they were looking at suicide attempts and rates among students in their schools as a way to engage community and advocacy organizations. And they mentioned here that that helped them navigate what they felt were inevitable roadblocks on the process to expanding services. And we heard from several the value of reaching out to the Centers for Medicaid and Medicaid Services, CMS, for guidance. This respondent highlighted that their experience in the past was hearing, nope, that won't work. But their experience recently has been, well, they hear from CMS, well, this won't work, but if you do this, it will. And they cited this as a huge change in terms of how helpful it was to work with CMS and the support that they are providing. Another thing that was frequently mentioned is don't rush. Consider implementation approaches that allow for adequate planning and buy-in. One respondent, and we heard this more than once, suggested giving yourself at least a year to bring in stakeholders at at all levels. So people talked about kind of the school, the education and the health side, making sure that you have buy-in and discussion there. But then also from the state down to the district, down to the school level, making sure you have buy-in and engagement there as well. And final finding I'll highlight is the value of proactively addressing potential stumbling blocks for local communities. So one respondent mentioned that they have kind of a collaborative atmosphere in their of their implementers. Rather than having 56 different plans of care, they share a template. And this was mentioned by several states as a helpful way to ease the administrative and paperwork burden. But I do want to mention we completed these interviews between fall of 2019 and spring of 2020, and we know this work and the lessons learned are ongoing. So we actually recently heard from some of our interviewees that they found stakeholders, specifically professional practice organizations that aligned with the provider type, were really helpful in providing guidance on documentation. So it seems there's many ideas and more than one possible approach for easing the paperwork burden. So thank you all. As I mentioned, our report will be released on Monday, December 14th on the Child Trends website. And we have, through these interviews, we heard two topics in particular come up as areas where states and districts were curious and wanted more information, or it was a roadblock they had hit. And that was on telehealth, specifically the availability of telehealth to meet students' behavioral health needs, and also on the difficulties of licensure. When the licensure someone needs to work in a school is different than the licensure they need to be able to successfully bill Medicaid, that was a potential stumbling block. So we did two short blogs really intensively diving into those topics and highlighting some state examples. So I believe these links will be posted in the chat, so you will have access to them. I don't want you to be trying to type this out. And at this point, I think we will move to questions. My co-presenters will turn back on their videos.
All right, Andrea, we have a couple of questions here.
Great.
The first one is, would Medicaid potentially cover the costs associated with universal social, emotional, and behavioral health screening?
I'm going to look to my co-presenters for an answer on that one.
I can take a first pass at it, and Sasha would love to have you jump in. I feel like we're probably going to say this more than once on this webinar, but it depends on your state. So every state, your state Medicaid plan is going to outline the services that are Medicaid eligible. And so it's if certain services are in there, that's how you would know if they are eligible. Your state plan, they're intended to be public documents. You should be able to look it up. I've also found what can be incredibly helpful is states usually have guidance on school district claiming that will specifically list out the services well and kind of provide more of a nuanced description of some of those services that you're more likely to see delivered in schools. I will say, on the topic of universal screenings, we get asked this a lot. It gets tricky when you look at more of those tier 1 services that could be delivered to students if they're done, as a whole, as a group. But theoretically, if they should be Medicaid eligible services if they are allowed within your state Medicaid plan.
I've got nothing to add. That was a great answer and totally agree.
Great. Thank you, Alex. The next question is, have any of the states that have expanded free care been able to use this to be reimbursed for asthma self-management education or any asthma medication administration in the school setting? So again, I think it depends on the state plan. I don't know. So no state have specifically added that as one of the new service through their state Medicaid, through their state plan amendment, but that doesn't mean that it wasn't an existing service. So again, I think where this would present an opportunity is that if that is a service that is Medicaid eligible within your state, and again, you could look within your state Medicaid plan, you could look within your school-based claiming guidance. If historically, you would have been school districts only would have been able to claim for those services if they were specifically written into a student's individualized education program. If you are in a state that is allowable and the state has expanded, now it would be Medicaid eligible for all Medicaid enrolled students within that school. But again, no states have specifically added that as a service, but it doesn't mean that it wasn't already within their state Medicaid plan and now could be claimed as a general education service.
Great. Another question here says, if states embrace this, would this require more licensed behavioral health practitioners in schools?
No, I mean, this doesn't require schools to do anything. I mean, it's a reimbursable service, so it'll certainly incentivize them to consider how they can afford to hire those people if they don't have them already, or expand them if they do. And a district that's already billing, for other things would obviously take advantage of the fact that they can now bill for these services, but it doesn't require districts to participate. And many districts, a few states have tried to mandate that all districts do Medicaid reimbursement. I think there's 2 or 3 of them that have done that, but for the most part, it's totally up to the local level whether or not you participate in the Medicaid program and to the extent to which you do.
While we're waiting for the next question, I wanted to mention that at the end, I'll end the Q&A about 2 minutes early, as we have some poll questions. One of them is, what other topics you'd like to have covered in webinars like this in the future? We've gotten a great response on this Healthy Schools Week that we are doing. And so there's tentative plans to offer it again. And so we want to make sure we're responsive to what you have questions about. So please stick around for those poll questions. I'd love everyone's thoughts.
Thanks, Sandra. Next question says, does implementing free care affect administrative claiming if schools are currently receiving that funding?
No, Sasha, do you want to do it, or? Okay, no, it does not. So there are 2, right? This kind of gets into the weeds around claiming, but there's typically kind of 2 separate streams of school-based claiming. So you can do administrative claiming, which is more for your activities like around outreach and enrollment, and then direct service claiming, which is for kind of your more what you think of, as the services that are being delivered in schools. And so they're separate. So this would really is about the direct service piece and being able to seek reimbursement for many more services that are delivered to the general student population. So it would not impact the admin claiming side of things. Sasha, is that anything to add on that?
No, that's exactly what I was going to say too. Yeah.
Great. Next, can you all speak a bit to the reimbursement lag that schools experience? In other words, do schools pay up front for services per pupil and then wait to hear about how much money they will be reimbursed? And do you see schools with deficits in the end for what was not recuperated?
I'll speak to the latter part of that. Yeah, for sure. I mean, it's not a dollar for dollar reimbursement by any means. It's I don't even want to estimate, maybe a quarter of the money that they're spending they get back from Medicaid. Maybe that number is too high even. So it's very helpful. And again, they can use Medicaid dollars to pay for personnel that serve non-Medicaid students. So they can use that money to pay for a mental health professional in their building to help pay that salary down, but that person is not by any means limited to just seeing Medicaid eligible students. So that's why this is such a valuable funding stream for the whole school community. But there definitely is a lag. I think, with cost-based reimbursement in particular, as I mentioned, there's, kind of a end of the year process by which they have to come to terms with what they actually spent versus what they thought they were going to spend. And sometimes it doesn't quite match up for a variety of different reasons. And then they have to fix that. Fee for service is a little bit more straightforward. I think there's a little bit more consistency in what they expect to receive, but they're definitely, cost-based is a quarterly reimbursement. So I'll just say that from the get-go. So yeah, you definitely, there is a lag. It's not instantaneous. And I think districts, typically have an idea of what they might get back when they're budgeting earlier in the year for Medicaid, and they can be a little bit accurate about, they can be fairly accurate about that, but it's not always obvious, especially in a year like the one we're having right now. The reimbursement's all over the place as a result of the pandemic and how that has changed things.
I would add, in our interviews with state and district leaders, we came in with questions about like, this is such an opportunity for health equity, and using language like expansion. And what we heard back was some states viewed it as a way that expansion might be the next step, but for now they're trying to get reimbursement for services they are already providing. So that would be a net benefit, ideally, if they're already providing the services and paying for it.
Great. So we have a couple questions about school nurses, so I'll read both parts. Is a school nurse a qualified Medicaid provider, and could Medicaid pay for a school nurse in a school where there is close to 100% free and reduced price lunch?
So it depends on your state. If the school nurse is a qualified Medicaid professional, I forget the exact term of art there, but yeah, it depends on the state. It depends on her licensure too, and again, that's state dependent as well. And then in terms of whether or not, it's helpful to know that there's a high percentage of kids who are on free and reduced lunch rate. That likely means that they are Medicaid eligible too, but there is a separate Medicaid. They have to be enrolled in Medicaid in order to get the traditional reimbursement under Medicaid. If they have a free care policy in place, it's a different thing, and I'll let Alex chime in on that.
That was great. Yes. No, I think it's right. I agreed with what you said around, it depends on state regarding school nurse and specific licensure requirements. Right. And it's not, Medicaid, the funds coming in from Medicaid could be used to support the salary of a school nurse. I think that's kind of the bigger picture, what the opportunity is. It sort of doesn't, you would assume that, districts that had 100% free and reduced lunch, they are going to have significant number of Medicaid enrollees. So it would definitely be in, their best interest to be claiming for as many services as possible, which would lead to additional funding, to support that school nursing position. But it's independent of the free and reduced, meal program as a whole.
Thank you. The next couple questions are about behavioral health services. So just one, can you speak more broadly to the topic of prevention behavioral health services delivered in schools? And put another way, have any states had success in the prevention space versus the diagnostic intervention space?
I think it's a fantastic question. And I think we're still kind of trying to wrap our heads around this piece. So you've touched on an issue that is top of mind for a lot of states. And I think as they're looking to expand their programs, there is a huge need and desire to figure out how to get additional reimbursement for some of those prevention services. And again, going back to the earlier question around universal screenings for social and emotional learning issues, it kind of those tier one services that you see, being delivered to the whole student population, regardless of whether or not the students are enrolled in Medicaid. So I think it's too early to tell kind of where, if there are successful examples. I know that states are very much thinking about it and, wanting to kind of pursue this as an opportunity to really support, getting reimbursements for those services. With that being said, I think what we certainly are hearing and seeing is that, again, this is an opportunity to bring in additional revenue. I really appreciate Sasha's point that, this is not, and Andra's as well, about districts don't have to do this, but, even if they do, that this is about, you can just begin by claiming for the services that you're delivering, and that can result in additional revenue. And that can provide, a really important funding source for delivering more of those prevention services and more of those universal screening services. So, that where that money gets reinvested, our hope is that, it can really be used to support some of those much, much needed mental health services. And we've seen that certainly, Kentucky is a nice example. They expanded, and really the catalyst for their expansion was concerns around school safety and wanting to bring in some more of those universal supports. And ensure access to mental health providers for all students.
Yeah, and I'll just jump in and say that one thing I didn't mention in my overview of the Medicaid program is that it is really the school-based program is really a district federal partnership. So it doesn't, we talk, as I'm sure many of you are aware, like the state budget's number one item is Medicaid spending, and then education is usually second or third in terms of what they're looking at. And given the fiscal crisis we have in states in particular with revenues so down, I mean, there's a lot of concern about how that's going to be rectified given the importance of the Medicaid program during a pandemic. So I say that because there's no cost to states to, if districts decide to increase their reimbursement for Medicaid services. In fact, a few states actually take a little money off the top for whatever reason, administrative or otherwise, the district really should be getting. So they sometimes even like make a little money off of the school-based Medicaid program in theory. So it's not, it's not something that's going to at all impact state budgets. If we talk about expanding Medicaid, and I think, you know, from working with the Hill for a long time, I try not to frame this as an expansion just because that has a lot of negative political connotations, but rather, you know, maximizing the efficiency of the reimbursement that districts are getting and ensuring that they're getting funding that they're entitled to, and kind of framing it that way. But again, this is something that is unique in the Medicaid space because the state really isn't the main actor in this. They're not paying for this. The district and the federal government is.
I think we have time for one more question.
Oh, great. Thanks, Sandra. So the last question I think is particularly relevant to the times we're living in now. Is the originating site reimbursement allowed for telehealth services provided to students in school clinics?
I don't know the answer.
I'm not quite. Yeah, so I guess I'm a little confused. So is the question, can schools get the originating site reimbursement? Is that the question?
I'll wait if there's a bit of clarification from this answer.
Okay. I'll assume it is and move forward with it. So yeah, so right. So telehealth has been, telehealth is, it's not a type of service, it's a modality of delivering services. We've seen that it was gaining significant traction pre-COVID. It has just taken off as being, you know, a tremendous modality for delivering services while schools have been closed. And yes, so the way it's typically structured is that school, you know, the school delivering the service is able to claim as the originating site of service and get that reimbursement. And then whoever's on the other end providing those services, the programs are structured in very many different ways. It could be a provider that's housed within a community clinic. It could be a school nurse sitting at the district level, kind of, then that provider is able to actually bill for the service. There's some great examples. South Carolina has a fantastic school telehealth program, and that's very much how they have it structured. The schools get the originating site of service fee, and then whoever's on the other end as the provider is able to actually bill for the service. So I hope that answers the question.
Thank you, Alex. I think at this point we will move to our poll questions. There's just 3. Before I do that, I want to thank you all and thank my co-presenters. We sincerely hope this has been helpful. So moving to the first poll question. I believe my colleague Emily is running the poll. Here we go. So first poll question, would you recommend this webinar to a colleague? Okay, poll open and closed. Go on to the next poll question. Did you learn something new today that you could apply to your work supporting health in schools? Closing this poll, okay. And finally, and this is something that you'll just type into the chat box, what other topics relating to supporting health in schools would you like to learn more about in the future? is the hour. I want to respect everyone's time, so please sign off when you need to. This is the last thing. You won't be missing content if you sign off now, but please do chime in with what topics you want to learn more about in the future. And thank you. Okay, I see a lot of people signing off. I think we'll go ahead and close the call. Thank you, everyone.
Thank you.